Art, I wanted to ask you, you see in upstate New York lots of variation in terms of the providers that you contract with and that you work with, probably larger organizations, small mom and pop organizations. When you think about delivery system redesign, talk about the variation that you see out there in the field and what you see happening in these organizations in upstate New York.
Sure. Well, first of all, I think that upstate New York is really a microcosm of the entire country. You know, you've got cities, you've got incredibly rural areas, but there's variation within upstate New York, which I think can teach a lesson that all of us can learn with the rest of the country. For example, you might have one delivery system when you've got a small city that's got one hospital, and every doctor is employed by the hospital, by the system. That's a much easier system to work with and to develop a plan with. On the other hand, when you've got a larger city with multiple hospitals, multiple systems, individual physicians may end up admitting patients to 2 or 3 different hospitals. They may like a doctor in one system if it's an endocrinologic problem, and a doctor in another system if it's an orthopedic problem, and for legitimate reasons, for quality. So developing a healthcare delivery system in that kind of an environment is different. So we are really at the stage in upstate New York, and I think elsewhere, where we don't know that there is that one size fits all. Maybe we'll get there at some point, and maybe someone on this panel will be the one to develop that.
Francois.
But yeah, Francois, Francois gets
unlikely.
but we're not there quite yet. Right. But what we are doing is we are making ourselves an available collaborative resource. There are physicians out there still, believe it or not, who are still taking notes and doing records by hand, not EMR.
I believe
there are doctors who are that mom and pop type of a doctor, and there's not another doctor within 50 miles of them. So there is a wide variation, and I'm hoping that we can come up with systems that are effective and good and that everybody can be part of.
So you know, it seems like we're asking these new delivery systems to do a lot. We want them to do population management. We want them to do care coordination. We want them to excel at quality measures, to take on risk, and to incorporate health information technology in everything that will be convenient for patients. Some might say that that's leading towards large mega organizations. You have to be a big organization in order to have the resources, the staff, the electronic information to do all this and, oh, by the way, take on risk. I mean, is that where this is headed, Francois, or do you think that's overkill?
I hope not. Well, first, I don't think you need all of that because there are ways of taking on financial risk, for example, that don't necessarily lead you to having tremendous amount of reserves. I mean, some of this is the insurance regulation needs to modify a little bit in many parts of the country. But if you think about the different functions that we're trying to conflate all together into a single organization, it's kind of silly, to tell you the truth, Dennis. If you start breaking them apart, then you can look at the different constituent pieces, and you know, one little sentence that always pops in my mind is this notion that form should follow function and function should follow incentives. And if you stick to that, then you start looking at, well, whose incentive do you need to change and for what? And then the functions around the patient, around those particular areas of care can evolve, and the organization can evolve around it as well. There's a lot of innovation, for example, in the risk-taking arena. We now see increasingly reinsurers starting to get into they're starting to understand that there's a big business in reinsuring not just large self-insured employers, but potentially creating a reinsurance layer for providers to take on a certain amount of financial risk. And then you have to put the boundaries around that financial risk. You know, the big issue to me is about what makes sense to patients at what point in time. So yeah, we want coordinated care, but you know what? 30 to 40% of health plan members consume less than $2,000 a year. And they need routine sick care, routine preventive care. go get it wherever you can, and if it's going to be out of pocket, go get it where it's less expensive and most convenient. Then you have a tranche that has one or more chronic conditions, and they do need a certain degree of coordinated care. And I don't think we've seen enough innovation, maybe you have, Ateev, but I don't think we've seen enough innovation in that arena yet. And then you might have procedural care that's needed for certain things. And yeah, I think your physician should be able to refer you at that point to whoever is best without locking you into a single kind of organization. So we need to be a lot more creative about what makes sense to the patient at what point in time. What type of risk does that mean? Is it manageable in the context of a particular procedure or a set of treatments? Is it manageable in the context of a longitudinal period of care around a certain number of conditions for the patient? Or if you're really a big organization and you want to take all of that on, that's fine. But we shouldn't in any way, shape, or form mandate that.
And I just want to emphasize that point. I'm with you, Francois, that I hope not. That's where we're headed.
Yeah.
But I think all the signal is that what we have done by delivery system reform has been consolidation. We see enormous hospital systems acquiring large physician groups, and in an effort to respond to some of the incentives we've created in terms of ACOs, and I am worried that we are headed in a direction that's probably not the right thing for patients. So while I'm with you that coordinated care is really important for a certain subset of our population, it's not clear to me that that is critical for all our patients. And in doing so, what we have really done is limited choice for them. And I'm struck by what do I hear when I speak with large organizations that are going down the ACO route. They want to decrease leakage. That means that a primary care physician who wants to refer to a cardiologist outside the system, they want to try to deter that.
Yeah, they want as much of the wallet share as they can
Exactly.
get.
And also, if they want to, they see other of these innovation models, retail clinics, et cetera, as a threat, and they're going to try to prevent patients, and prevent is a loose term, but try to discourage patients from going out of the system. And so I am worried that there are two downsides. First, it's limiting patient choice. And it's encouraging consolidation. And when you have a large organization that has a lot of market power, we know what happens is they drive up prices. And so I think it's a strong concern shared by many, and it's something we need to be aware of.
So it's interesting.